Thanks again to all of you for making time to attend today. We do have a lot to cover, so I'm going to move through our intro slides pretty quickly since it's most likely the second time that you have seen them. The National Center for Health and Public Housing is very grateful for the support that we receive from HRSA to provide training and technical assistance to health centers. With their support, we are able to work directly with housing authorities and health centers and other organizations to improve access, quality of care, and health equity, and ultimately improve health outcomes for public housing residents. However, the views and the comments that we make today are our own and don't necessarily represent the views of HRSA or HHS or the federal government. Before we begin, I do want to answer Danish's question about funding from last week. We all know that the rescue plan provided $6 billion to health centers, but I didn't know the details of the scope and the distribution on our last session. So I put in two links into the chat. The first one is NACHC's press release. And then the second one is a link from HRSA on the dollars that are being sent to each health center. And it's a map, so you can see amounts by state as well as individual health centers on there. And the money is, it's COVID related. So the scope of the funds are to support and expand vaccination, testing, treatment for vulnerable populations, as well as just deliver healthcare services to those who are high at risk for COVID, and expand operational capacity. And that includes physical infrastructure and mobile units. So it's very broad, and hopefully that will help all of you all continue the great work that you're doing. So now just for some housekeeping items, we want this to be as engaging, as welcome, as informal as possible. So if you feel comfortable, feel free to turn on your video. You are on mute right now, but we'll open that up during the Q&A. So you can ask questions freely. I'm sorry if you can hear, can you hear that? The lawn? Sorry, you can hear it. We have this on Tuesdays. Tuesday's the day that the grass gets cut, so I apologize. But I'll go on mute in a little bit. In the meantime, if you do need to speak up, we can unmute you. Just use the raise hand icon. We are recording this session, and the slides and the recording will be posted to Moodle, and I'll send that by email. I did send out the slides and the recording for last week. If you didn't get it, just let me know and we can drop that link in the chat. Actually, Fide is going to be the one that drops the link in the chat just in case. Again, the chat is open, and we encourage you to use it throughout the session. So while you're listening, add your thoughts, add your questions as they come to you, so that when we do get to the Q&A, it's going to be ready to go. If you see something, please feel free to comment as well. And now, please go ahead and introduce yourselves in the chat so that we can all see who's here today. You can enter your name, your health center, and your location. And while you all are doing that, I'm going to move on. So I just want to remind you about Moodle for the slides, the recordings, the resources. I am going to ask Fide to upload some resources on screening tools after today's session, so there'll be some new material on there as well. So check that out if you can. Again, my name is Sanki Malik Cho. I'm the Director of Research Policy and Health Promotion here at the National Center. I'm joined by my colleagues, Dr. Adine Naboyo Rios, who will be helping to moderate today's session, and my colleagues, Fide Pineda Sandoval and Chantel Moore, who will be helping with the polling and the chat and all of the tech challenges. Hopefully there aren't any, but just in case, Chantel's here to help with that. Also joining us today is our guest speaker, Mr. Joe Lee from the Association of Asian and Pacific Community Health Organizations. Joe is, I'm going to go ahead and introduce him. Joe is the Director of Strategic Initiatives and Partnerships at AAPCHO, which is an organization dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders. Before joining AAPCHO, Joe worked for the Alameda Health Consortium and Community Health Center Network, which is a regional primary care association, and managed services organization based in East Bay of California. He holds a Master's of Science degree in Healthcare Administration and Interprofessional Leadership from UCSF and a bachelor's degree from UC Berkeley. And we are very glad that he's going to be able to join us today. AAPCHO collaborated with NAC and with Oregon PCA to bring PRAPARE into the health center world. So he is our expert on the tool, and he's worked at a health center. So he's able to bring all of those experiences with us today. We do have a lot to cover. We're going to do a quick recap of the first session. And then I snuck an item in here. I'd really like to talk about a couple of domains and topics that may not be in a standardized screener, but are important to consider for public housing and other vulnerable populations. It's very important to me. And I promised Deb Dean that I will keep it short. So he made me remove a lot of my slides on this, but it's in there, so I'm glad for that. And then we're going to talk about how to choose a standardized screener, what criteria to consider, walk through what it looks like to apply that criteria to a particular tool. Many of you that are on here are new to screening, so hopefully that helps you organize your thoughts on it. And then for the veteran screeners on the call, if there are additional items that you think that are missing, please add that to the discussion on the chat. And then we're going to hand it off to Joe to talk about PRAPARE, which is very exciting. And now I'm going to pass it on to Abdeen.
Hi, everyone. Good afternoon. The guiding questions for today are: what is the range and diversity of screening tools and how do they compare? Also, how can determination be made about the adequacy of these screening tools as well as their quality? And finally, among the various screening tools, how does PRAPARE rank? And now for the guide to the screening tools, sorry about that, hiatus. Compare, learning objectives is to compare the most common SDOH screening tools. Also to determine the best SDOH screening tools for your patient population and needs of your organization, as well as describe the PRAPARE tool and evaluate its potential application at your health center. Now, reviewing our last session, session number 1, several key concepts that relate to SDOH were covered during that session. For one, we learned that SDOH just recently entered the field of health and that it always relates to health outcomes. Always, always. As a result, we further learn that the health field has changed or has morphed over time. Folks, I am sorry, I lost my connection.
We can still hear you, sir.
You still hear me? Okay.
Yes.
Sorry, this dropped on top of me all of a sudden. As a result, we further learned that the health field has changed or has morphed in significant ways. It has gone much beyond the tradition of merely seeing a medical doctor. So what does this mean? It means that today's medical model is now complemented by a social determinants of health model. So if you remember anything about that webinar, think of the medical model and the SDOH model as inevitable twins. Today, we have a medical model and a social determinants of health model. So what's the point? Neither should exist without the other. Now, another major learning is that our social environment has more to do with our health than even our medicine. Now, this is very, very powerful information. So let's please underscore the fact that SDOH has greater impact on health than clinical care. In fact, research indicates SDOH is about 6 times more powerful than clinical care itself. For another, we also learned that the effects of SDOH strongly impacts all communities. We know that it more strongly affects low-income and public housing communities in general. In addition, we also learned that issues around race and culture fully relate to the social determinants of health. And the question is why? And the answer is because the way we think and how we behave is greatly determined by our culture and our upbringing. So, as such, race and culture become critical SDOH factors. So here, race and culture work at both the individual as well as the institutional level, but also at the social level. Finally, what else did we learn? Well, we learned that there are helpful processes, resources, methods on how to make the SDOH model work well, especially screening tools that can help diagnose what is going on. And that is where we want to zero in for today. So welcome to the adventure. Glad you joined us. And let me turn it back to Saki.
Thanks so much, Abdeen. So just quickly to continue on the recap, here are the domains that we talked about last time from the IOM. They cover socioeconomic domains, financial strain, mental health and health behaviors, community connection, exposure to violence, and neighborhood conditions. There are 2 more items that I would like for you all to consider, and that's digital health literacy, access to broadband, and then legal needs. And what I mean when I say digital health literacy is the ability for an individual to seek, to find, to understand, and to appraise health information from electronic sources. The disparities in access to broadband internet were apparent long before the pandemic, but COVID has really highlighted just how important internet access is. In the past year, everyone's virtual engagement has increased exponentially with virtual meetings, with the online learning with schools, as well as with engagement in the healthcare system by the way that health centers have had to pivot a lot in the earlier days of the pandemic from inpatient visits to telehealth services and rely heavily on patient portals and text messaging for patient engagement. The patient portals being used for health education, on COVID testing, on vaccination information, and then normal things like diabetes education and remote monitoring of health conditions, as well as case management for behavioral services. So for all of those items, it's very critical for the health of public housing residents and other vulnerable populations to be able to understand and navigate those systems. And also other vulnerable populations like the elderly and low-income individuals. These are groups that are less likely to use digital health technology, have low levels of digital health literacy, and those who are disabled are 3 times more likely to say that they never go online. One of the reasons why it's not on the IOM list is because in 2014, it didn't meet the IOM stringent criteria. And that's because, to my knowledge, there's only one scale that's been validated to capture the knowledge, the comfort, the skills at finding and evaluating and applying electronic health information. And you can see here, as stated by the Chief of Operations at SDOH Health Systems, it's not only access to housing and food and pharmacy, but also broadband and text messaging services that can have a really severe impact on patient engagement. So I am going to try and launch a poll and ask you all about your screening for this. So I'm going to launch it. Chantel, will you help me with that?
Sure. Do you currently screen for digital health literacy or broadband access?
The reason why I'm asking this is because I asked this question at one of our presentations in the fall, and it was no across the board. So I'm just wondering if anybody else is. Okay, I'm ending it.
Okay, 100% of our participants answered no.
Okay, so that's very good to know. Okay. So since you guys aren't, here are some sample questions to consider about access to the internet. What types of devices are being used to access internet, where internet is accessed, the level of comfort in using patient portals or other types of digital communication. There's also opportunities to partner with other organizations to improve broadband access. For example, HUD has a pilot called Connect Home that works with multiple stakeholders to bring internet devices and training into public housing neighborhoods. Libraries across the country can provide health literacy education and training, and this is an example for one, and that's in Richmond. And then there are resources internationally like IC Health that provides online training in many different languages.
Saki, just want to let you know that Danisha Reed has her hand raised.
Oh, okay, Danisha. You can unmute.
Hey,
go ahead.
I wanted to raise my hand about the digital literacy question. So you end up addressing a little bit, but a lot of the digital literacy barriers that people typically present upon either registration or within a health center is related to patient portal, email access. How do I use patient portal? What does that look like on my phone versus on a computer? So we have had questions surrounding patient portal, especially when we have patient portal campaigns and things like that. So I do know that's a big issue. And then what we have been doing to kind of combat that is referring people to, at least before the pandemic, was referring people to the local library for like different computer programming classes and learning how to do that, because we're in Chicago. So Chicago Library has a lot of programming for like adults and seniors for literacy and digital, learning and things like that. But with the libraries closing and reopening and then closing and reopening, like our go-to program or to refer people has been unavailable to them. So a lot of it has been them working with the youth of their family to kind of help them use the smartphones and pull up the apps and make the little the shortcut on their phones so they can go straight to it. So we've kind of had like some impromptu workarounds to help people access patient portal to, I guess, increase their digital literacy and of course access to their providers and telehealth and things like that. But it has been a barrier when trying to refer them to programs that would help them learn on their own time, because so much stuff has been closed, and then all the classes they do have, it's like, oh, well, get online. And it's like, well, that's the problem. So
thank you so much for sharing that. Those are really great tips for everyone to hear. I will be asking you all later on in the evaluation poll whether or not you want some more tips or tricks or resources on those topics, and we can add those to Moodle as well. So just the last item that I wanted to bring up is on legal needs and legal services. There's one screener, iHelp, the one that has 2 L's, that does include a legal domain, but many of them don't. So that's why I'd like to draw your attention to it. And I'm borrowing this slide from our friends at the Medical Legal Partnerships. We did a presentation together last week with them. And Bethany Hamilton, who's the co-director of MLP, described how lawyers can help address patients' social needs. And in the slide, she's referring to the iHelp 1L screening tool and a list of the domains covered. But her main point here was that if a patient has been denied SNAP, disability, utility, or health insurance benefits, a lawyer can help figure out what kind of documentation is necessary to prove eligibility. They can also help navigate evictions or shutoffs or hold landlords accountable for poor housing conditions. They can help ensure appropriate accommodations for disabled in employment and education settings. And they can also help with immigration as well as criminal background expungement, which of course has implications for the eligibility of public housing. And then a very relevant and important item here is helping individuals experiencing domestic violence get orders of protection or help with child support. So this was Bethany's slide to encourage folks to consider having a medical legal partnership in-house that would have lawyers on hand to help navigate all of these issues that are being screened, but also just important to remember those legal follow-up questions. So I just mentioned this, but we will be adding a question on the evaluation pool. If you need more information about any of those topics, I'm happy to provide some more. Okay. Next, I just want to share what screening tools health centers are using. So this is from 2019 UDS, and these aren't exact percentages. There are some overlaps when health centers report that they're using more than one tool, but these are just approximations. And you can see here that 30% of health centers are reporting that they aren't using a standardized screening tool. But most health centers that do screen are using the PRAPARE tool. So it's really great that Joe is here today. Followed by the accountable health communities and the WeCare tool. Upstream's risks was also on there. And then there are a number of just other tools that were mentioned in UDS, but not very many health centers reporting that. By and large, most folks are using PRAPARE. Here is a laundry list of other screening tools that you can choose from, and it is long. This is not exhaustive. We'll be posting some information about all of these different screening tools onto Moodle, but there are a lot of choices available. So to help understand, how to choose which one moving forward with your health center, just a reminder of the criteria that IOM used for the domains, which was the strength of the evidence between the domain and health, the usefulness for improving patient care, whether there's a reliable and valid way to measure that domain, if it's feasible to do it in a way that's sensitive to patients' privacy, whether or not that information can be found elsewhere. The criteria for North Carolina was that the domains be linked to health, that their questions were validated and brief and aligned with other tools. Some other criteria that are important to consider, in addition to what domains are covered, is the overall length of the assessment, how many questions it is, will the length of the survey cause a burden to patients, what is the reading level of the assessment, is the language written appropriately for your patient mix. And in just a minute, I'm going to go over how questions can vary from tool to tool. Also important is the tool available in other languages that represent the diversity of your patients? Is it free? Is there a cost associated? How easily can the tool be integrated into your EHR? Does it depend on which vendor you're using? Is there flexibility in the tool? Can you modify questions? Can you add questions? And what kind of resources are needed from an IT standpoint or a staff training standpoint in order to implement the tool? And then finally, whether the tool is validated and then the rating or the ranking of that tool. So some people at Kaiser Permanente and Siren work together to develop a rating system for screening tools. And I have a link to that in our resources slide. So I just want to briefly show you how questions on a particular domain can vary by the tool that's being used. And in this slide, I'm comparing the questions for housing insecurity and homelessness across 9 tools. And I just chose those 9 tools because that's how many I could fit on the slide. But you can see here that there are many different approaches. Some tools like the Accountable Health Communities tool and the Medicare Total Health Assessment and PRAPARE ask folks to describe their current living situation. And then there are multiple options that describe certain scenarios, like I have a steady place to live, or I do not have a steady place, with some examples of what that might include. Other tools ask a more direct yes/no question, like are you in a shelter? Are you living in Section 8? And some ask whether an individual has concerns or is worried about losing their housing, or if they're at risk, feel like they're at risk for homelessness, which is very different from where you're currently living. Some ask questions about whether they need help, if they say they're worried, and here's where a legal needs question might fit in as a follow-up. And then in North Carolina, they ask about homelessness within the past 12 months. So adding that time period, which could be an indicator of other types of risks or needs. So I just wanted to point out those differences. All of the questions have been validated. All of these screening tools themselves have been. So it's more just a question of understanding what's being asked specifically, if that fits your needs, and then if you need to do any additional follow-up. And then the last row shows the reading levels for the tool. You can see the range here. The Medicare tool is at the college level, while the WellRx is at the second level. So now I'm just going to provide an example of how to apply all of that criteria to a screening tool. I'm going to use the CMS Accountable Health Communities Health-Related Social Needs Screening Tool as an example. So it's a 10-item tool that can help providers find out patient needs in 5 core domains: housing instability, food insecurity, transportation problems, utility help needs, and interpersonal safety. And it's unique in that it combines screening across these 5 domains into only 10 questions. And there are a few social needs screening tools that are able to achieve that same breadth and brevity. It only takes about 5 minutes to complete. The questions are at an 8th grade reading level, and it's available in multiple language, and it's free. The questions in the tool are meant to be used for individual respondents who are able to answer the questions themselves. A parent or a caregiver can also answer for an individual, if that makes more sense. And then clinicians and their staff can easily use the tool as part of their clinical workflows for people of all different ages, backgrounds, and settings. There's also some flexibility, some supplemental domains to add if you need that for your population. Because it is an established and validated tool, there are several EHR systems that have adapted to make it more user-friendly. The bigger vendors like NextGen, Epic, Clinical Work, and Allscripts all have compatibility. And there's probably more. I'm not sure, but those at least are able to work with the AHC very well. So that's just one tool to consider. And that's it for me. And now I'm happy to pass it off to our guest speaker, Joe Lee, to give you a lot more information about PRAPARE. So I'm going to stop sharing my screen. And Joe, welcome.
Hi, hello. Thank you, Saki. Thank you, Abdeen. Hello, everyone. It's nice to meet folks here. I'm super excited to be here. I'm going to share my screen so I can show you a wonderful visual, aka my PowerPoint. So I'm going to pull this up. All right. Okay. Can everyone see this okay? Can I get a confirmation? I see nods and a thumbs up. Fabulous. Okay, great. So I have about 15-20 minutes of content, and I'm going to try to leave enough time for questions. And of course, if you have any questions or comments or like to make oohs and ahs, you can say that in the chat box. So feel free to chime in. I love an engaging audience. You can probably tell that I'm a very extroverted person. And for extroverts like myself, my energy gets fed off. I get my energy from other people in the room. So the more active you are in the chat box, or the more active you are using your emojis on Zoom, I definitely appreciate it. So again, my name is Joe Lee. I work as the Director of Strategic Initiatives and Partnerships at the Association of Asian Pacific Community Health Organizations, or also known as AAPCHO for short. We're a national association, just like NCHPH. We really advocate for Asian Americans, Native Hawaiians, and Pacific Islanders who are minoritized and marginalized. And we are dedicated to improving, really driving health equity for medically underserved populations across the US, the continental US, Hawaii, and the US affiliated Pacific Islands. Just like NCHPH, we're a NTAP, a National Health Center Training and Technical Assistance Partner. And I just want to say that I'm a big fan of Saki and Abdeen's organization because when I used to work at the clinic, I used to work at Lifelong Medical Care in the Bay Area of California, hence the Bay Area kind of like, you know, Zoom background here, honoring my home in a way. When I used to work at the clinic, one of my many hats I used to wear was supportive housing. And so I have a really deep love for supportive housing work and public housing work, and have just seen some amazing interventions. And all the folks who introduced themselves earlier, Danisha, Lisa, Amelia, Erin, Charisse in particular, I think most of your CHWs and managers, and population health and grants. I used to work with like, your types of positions, and that was like the golden time of my of my community health career. And not that I'm complaining to be here. This is amazing. I get to connect with other people across the nation. I just want to say thank you for, yes, the golden times. So I just want to thank you for your invaluable work. I'm part of this big partnership team of PRAPARE. Some of you may know about PRAPARE. For those of you who don't, I'm going to talk about it just to provide a brief introduction to it. And for folks who are already PRAPARE users and PRAPARE experts, feel free to use this presentation as like as educational content that you can repurpose for any new staff or providers that you onboard. And so for those who are not familiar with PRAPARE, this is a good intro to you. So I'm part of this fabulous team of PRAPARE founders, AAPCHO and the National Association of Community Health Centers and Oregon Primary Care Association. This is what we all used to look like before the pandemic. Here are our learning objectives here. So number one, I'm just going to spend a few minutes talking about PRAPARE. And number two, I'm really going to focus on this part here, SDOH data collection strategies. And what does this look like in the real, like on the ground? And I think there's the background. And you might want to mute your mics if you haven't already. Okay, great. So, and I'm going to spend a lot of time talking about number two here, SDOH data collection strategies, because I feel like what we are learning from the field is that people really want to learn about workflows. How do we get this done? How do we collect social needs data and really accurately assess the social needs of our patients? And then lastly, I'm going to, if we have time, talk about some of the higher level, right, like social needs, or how SDOH screening can impact different levels of care, how it can align with their priorities and all that jazz. So if there's anything else you want me to cover, just let me know. I'm more than happy to do so. So let's get the party started. We're gonna talk about PRAPARE, and feel free to chat in the chat box. Are you a PRAPARE user? Are you familiar with PRAPARE? I see some nods. If you've never heard of PRAPARE, chat in the chat box and let me know. So for those who know about PRAPARE, this is the big why, right? We know, as Abdeen and Zaki mentioned earlier, really more than 50% of our health really is because of some of these drivers, right? The social and economic factors, our physical and environmental factors. We know that things like poverty and income, housing, where we live, our education, our built environment, it really influences our health status, right? And this is, something that knowing that we have social determinants of health that are really driving health outcomes, how can we collect, standardized data on social determinants of health so that we can make a meaningful impact on all of these different areas right here. So I'm going to, kind of reset my marker here. I love drawing, if you can tell. So this is something that with standardized SDOH data, we can use this data to really kind of really advocate for our patients and our family members, right? Our housing clients too. Can we leverage SDOH data to empower folks to improve their health and well-being? How do we address the structures, right, that we have in place that could be facilitating or restricting healthcare? How do we ensure that our standardized data can help redesign our care team? Like, do we have enough CHWs? Do we have enough enabling services folks to really meet the patient and population needs here? And then for those who are in a more like managerial position, how can we really influence the system, right? And the policies that really kind of drive or don't drive health equity work. So for example, payment models, right? So, we often get very little or no reimbursement for all the essential enabling services or non-clinical services that we do for our patients, right? So our vision is, hey, let's get reimbursed, right? If we're reimbursing clinicians to resolve, to help with medical care, let's also establish a reimbursement system for social interventions too. Can I get an amen for that? So we can, hopefully we can strive for that. And also, Another reason to collect standardized data on social determinants of health is so that we can really have a social determinant strategy. So when we have a social determinant strategy, we can, really build resources like building new resources, in-house, for same-day use, and things like a children's book corner to address to improve literacy rates, establishing food banks or partnerships with food banks to address food insecurity, all the way to the system and policy level. How can we work with our friends in the Medicaid and Medicare agencies to really influence meaningful policies here? Okay, the chat box is blowing up. I will respond to them, those comments soon. So PRAPARE, is one of those standardized kind of SDOH screening tools. There are many, as Saki showed you earlier. This stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. And I'm going to just check in on the chat box here really quickly, just to look at some comments here. Okay, fabulous. So Aaron has a question about the PRAPARE form, asking some demographic question. And I can certainly speak to why some demographics were included, but not others. I can certainly touch on that, Aaron. And let's see, Denisha says we implemented another SDOH collection survey related to access to healthcare and services. We also asked if they visited a food pantry in the past 6 months. We use this data for patient engagement outreach. Nice, nice. And to get them scheduled for services and forward data to the grant writers to secure more funding. Yes, you can use this data for all sorts of things, right? For funding, for service enhancement. You can, identify local food pantries and pop-ups for your patients. That's awesome, Denisha. And then thanks, Jeanette, for sharing that you use PRAPARE as part of the patient's electronic medical record. Okay, fabulous. So I think a lot of folks are familiar with PRAPARE here. Who's not familiar with PRAPARE? And feel free to, don't be shy. It's okay if you have limited or no knowledge of PRAPARE, or if you're not using it. It'll let me tailor this part of the presentation. So with PRAPARE, for all the existing users here, that this is a standardized risk assessment. It's a protocol that's already built. It was designed to be built into the EHR. We acknowledge that this might be some barriers, right, for the other screening tools. Maybe they weren't built, with EHRs in mind. But I think this is why I think health centers are using PRAPARE a lot, because there are so many EHR templates. And for the demographic, some of the assessment questions, these are some of the questions that you'll see on PRAPARE. So I'll start on this left-hand side. Questions, let's see, 1 through 9 over here, right? These are the core questions, right? And if you might recall, these are UDS measures, right? These are UDS measures that are automatically populated into PRAPARE EHR templates. So you really don't need to ask these questions, right, when you're screening for social needs, because this is something that's already captured, right, for UDS. Some of the additional questions, and so when people ask you, well, oh my gosh, there's so many questions, you're absolutely right, there's 21 of them, and that's a lot, right, to ask for one single individual. But just keep in mind that you might be already collecting this data. So how do we lessen duplication, right? Opportunities for duplication, and how do we think about efficiency, right? In terms of what questions do we need to ask that we're not asking, and later on we can aggregate those data results, right? So some of the unique questions that PRAPARE is asking are these right here, and then here's some optional ones which are here for you to read. You'll receive the slides later. And to answer, it was Aaron's question. Aaron, would you like to clarify? Oh, you did actually. We did ask for ethnicity and race, but we didn't include things like gender identity and sexual orientation. Well, I have good news for you, Aaron. We are going to include that in the PRAPARE 2.0, or that's the plan when we revise this tool. And we are working actively with the Fenway Institute, the National LGBTQIA+ Health Education Center. We are actually doing a learning collaborative on SDOH collection and SOGI data collection. At the time, from what I recall, the PRAPARE founders, they didn't include SOGI, sexual orientation, gender identity, because they wanted to respect that there was a SOGI data collection initiative in place. So we don't want to step on any toes at the time, but this is a great time to merge, right? And just because PRAPARE isn't asking these questions doesn't mean you can't ask those questions, right? You can add, right, like additional demographic questions. You can add questions that might be related to specific social needs that that you see as a phenomenon, right, in your particular population. And yes, Stephanie asks, UDS stands for Uniform Data System. So it's just, yes, thank you, Saki. It's the data that, that every FQHC is required to collect. So I know let's see, who's the grants manager in this room? Erin probably knows. She probably deals with UDS all the time. So this is, some of the questions that are asked. So I'm going to, some people, I received a good question about, how was PRAPARE developed, right? And this is something that I'm really proud. I mean, I'm biased, right? I'm part of a PRAPARE partnership team. There are other amazing SDOH screening tools out there. But I just want to let folks know that, PRAPARE was built in a way where it was really meant for health centers and to ensure that there's a patient-centered process, right? So some of the, scoring criteria that we had include things like alignment with national initiatives, right? Like Healthy People 2020. Now we're going to go into 2030, ICD-10, meaningful use, things like that. And we also wanted to make sure that that this data was not going to be too burdensome, right, to collect, right? We don't want to ask too many questions. Can this be built into the EHR? We also wanted to ensure that the criteria included actionability. If we're going to ask a question about social needs, are we able to take action, right, on those social needs? And this is an ethical, right, issue, right? Like, why would we ask, people about food insecurity, right, if we aren't able to respond with food resources? And this is a common, comment that I hear from health centers. There's something that, there's a lot of planning that we need to do. Whatever resources that we can offer in-house or resources that we can offer because of our community partnerships. So this is just some of the criteria that, and also sensitivity. Sensitivity was also factored in. I received a good question around, how the housing status PRAPARE question was phrased, and Saki showed the example of that earlier. This is something that I asked our principal investigators, our co-PIs, and they can't remember the details offhand in terms of how they reached address the sensitivity level. But we did have plenty of face-to-face stakeholder meetings with pilot participants, including health centers and HCCNs. And I remember sensitivity was discussed in terms of when we ask each question. And I remember things like, in Hawaii, like our health centers mentioned, hey, remember you include on the beach, right, when you're asking about housing status, because just making sure that you're tailoring the question to be culturally responsive, right, to the geographic locations in which y'all are serving in. And also something that we really emphasize, this is just a technical part, right, of PRAPARE. There's the human emotional part, right? There's the human part to this. How can we use motivational interviewing, empathic inquiry, talk story, right? How can we use these kind of patient engagement strategies to answer these questions in a very sensitive way, right? That's not triggering, that's not too traumatizing, things like that. So how do we have a trauma-informed, approach? And I know all the housing folks know the trauma-informed models really well. So I'm going to skip over to, let's see, you're going to receive a big slide deck later. I have 50 slides, but I'm going to show only a portion of it. Jeanette's laughing. And so these are all the EHR templates, right, that are here. Now, here's the scary thing about EHR world. Everyone does their own thing, right? They have their own template, they have their own number of clicks, right? Not all enabling services have staff like CHWs have access to EHRs. So this is the technical operations piece that we all got to figure out. But there are a lot of free templates out there that's available for use. And in the slide deck, you'll have an opportunity to explore what some of those templates look like. So that's learning objective number 1. And I'm going to actually skip over this poll question for today because I just want to be mindful of time. I hope that's okay, Saki. Sorry, I know you were prepared to launch the poll. But if you are using specific EHRs, feel free to just chat it in the chat box. We're actually documenting what the EHR related challenges are. So if you're using an EHR and you are using SDOH screening tool like PRAPARE, let us know what those challenges are. Is it easily accessible? Is the data easily transferable? Is it reportable? Things like that, because that's a critical component, right? When you're working with data. I want to talk about this section for a little bit. SDOH data collection strategies. So this is the PRAPARE paper tool that most of you are familiar with. And I'm just going to link it in a chat box for your reference. You can download it. It's a one-pager, right? Both sides. Thanks, Amelia, for mentioning that you use eClinicalWorks. Curious if you're using the smart form in the ECW. So this is the PRAPARE form. This is translated in over 26 languages. So this is another thing that we're really proud of, that not many SDOH screening tools are translated beyond English and Spanish, but we have 26 languages. And those languages are all of these languages here, and like Marshallese, Swahili, Lao, Tongan, Hindi, Russian, Bengali. So there's a lot of translations out there. And we make sure that these forms are translated and validated by the community. If you are like me and you're an Excel geek, an Excel nerd, just like me, you can download the Excel data collection, the Excel template, and kind of play around with the PRAPARE form, and especially for those who are not using EMRs or EHRs on a day-to-day basis. And when when you open, and this is something that you can access on our website, you can go to, let's see, I'll send the website link later. Okay, here you go. This is, if you go to nac.org/prepare, you can find this information. You can download all the kind of paper tools and the Excel templates there. Let's see. So I'm going to go back to, in terms of the SDOH data collection. So with the paper tool, with this Excel template, or in your EHRs, when we talk about data collection, like the actual process of collecting data, we really want to promote this best practice right here. So to ensure that you're not asking these questions more than once, right, across your workforce, across your health center, make sure that you review your intake forms, right, like your general patient information form, your new patient form, if you're doing PHQ-9 screenings, if you're doing nutrition assessments. There are some questions that you might already be asking that's, that crosses over, that overlaps with the PRAPARE domains, right? So look at your income verification forms, your self-management forms, and highlight those questions in your intake forms, and just do a really quick crosswalk, right? We found that in South Dakota, North Dakota, one of the health centers we work there, we found that one of the health centers was already asking up to almost 80% of the questions. So they really just need to add maybe 2 or 3 questions to their intake process. So this is a really best practice. If you need assistance with crosswalking the data, work with your primary care association. This is something that we found to be best practice, where the primary care association has all these, hopefully your primary care association can have the tools to help you do a crosswalk and do this quality improvement process. I'm going to give you an example right here. So say, for example, a community health worker, they might be able to add a question to their general patient information form for like transportation, for example, right? And the PRAPARE assessment asks, has the lack of transportation kept you from medical appointments, meetings, work, or from getting things needed for daily living? And the answer options include, yes, it has kept me from medical appointments or getting my medications, or it has kept me from non-medical meetings, appointments, work, and so forth. So this QI process, right, can also entail ensuring that the health centers, that your health center's EHR system is capturing this information in an automated way, or that the data is being inputted by an assigned team member. And then also, if we look over here, the QI process can include with an SDOH response strategy, right? So I showed this earlier, right? I just circled some of the key aspects around transportation. So maybe a yes answer to transportation need question can notify a CHW, such as, or to arrange a transportation shuttle, or maybe the manager of the clinic can build a community or government partnership that offers, emergency transportation assistance, things like that. So, think about, your quality improvement process. And I would encourage you all to work with your quality improvement department. This is a fun project, right? Like little operational changes that can really help your workflow from collecting data to responding to data. This is something that I would love to share this with you all as a framework. As you're mapping out your SDOH data collection strategies, whether you're collecting data right now or want to collect more data in the future, or maybe you haven't started yet and you're wondering where the heck do I start? So this is called the 5 rights framework. Ask yourselves what, how, who, where, when, and then what information do we need to collect, right? What are questions that we don't already ask to determine social needs? How are we going to collect it? Is it by paper? Is it through an Excel sheet? EHR? Is it through a tablet? Through an app? Who's going to collect it? Is it the clinician? Is it the CHW? Is it the front desk? Where are we going to collect it? Is it in the waiting room? Is it in the Zoom room? And when are we going to collect it? Is it before the appointment, during the appointment, after the appointment? And we love this no wrong door approach. There's no silver, there's no unicorn solution to this. The workflow really depends on, yes, I said unicorn solution, and I'm gonna use that. There's a unicorn solution to this. It's really dependent on the way your health center works, right? The way your operations are set up, who you have in your workforce. And you'll have the slides to this, but this is a really good exercise for you all to get together with you and another team member, or maybe with your QI team, or with your SDOH team if you have one. Ask yourself these questions and have a 1-hour brainstorm meeting. And then after that, identify, build out these specific workflows that could be, that makes sense for you, right? So for example, who will collect the data? Who has access to, EHR, the EHR to input the data? Who needs to see the data, right? That's really important. Who will respond to the data? And, we're learning that, the best, some of the most responsive health centers are those who have a very multidisciplinary, interdisciplinary team of clinical and non-clinical providers. So, hopefully this will address some of the, any silos that you might be experiencing. I know when I used to work at a health center, there was always a, this kind of barrier, clinicians and non-clinicians. How do we, kumbaya, come together, address social needs for our patient populations and our housing clients? Okay. All right, I'm going to, and then if you're interested, this is kind of an advanced kind of version of workflows. This is something that I really have been inspired by lately. This is a clinical, this is called swim lane diagram, where you can map out, okay, this is where the patient arrives, right? And they can take this, they self-administer PRAPARE, for example. All right, what's next? We have the provider who's going to see the patient here, right? When is our clinical support team going to get involved, right? And then all the way to how do we ensure that we get them referred out to a community-based organization to address housing needs, for example, or is there an in-house service, right? So the swim lane diagram is a really robust process, an easy way to visualize and organize your workflow and your SDOH data collection and response strategies. Okay. I'm running out of time. I only have 1 more minute. So I'm going to leave you with this one last slide here. Some of you might be thinking, oh, this is a lot of work. Maybe it has been a lot of work. Some of you might be thinking this is going to be a lot of work. I would encourage you all to reframe kind of SDOH data collection as, not look at it as a separate project, but really looking at it as how is it aligned with your current work, right? How is it aligned with your existing initiatives? I know some of you are community health workers, right? How can this, how can SDOH data collection help demonstrate the value of your CHW initiatives, right? If your entire CHW workforce is able to capture data on social needs and validate, right, some of the community concerns that are happening, right? How can this data be used to help expand the need for more CHWs or case managers, right, for housing, for example? Look at your quality incentives. Look at some of your statewide or local payment reform efforts. There are a lot of pilots out there, right, that some health systems or some governments are willing to pay, right, for to help expand SDOH screening initiatives. So these are just some kind of macro level, just high level things for y'all to think about. Okay, I think I'm gonna just wrap it up there. There's a lot of, there's a lot of things that I can share in this presentation. You're just getting just a brief introduction to it, or reintroduction to it, and maybe we can spend the rest of the time to answer any questions. So you can answer me, or you can answer me. You can email me here at jolie@apcho.org, and my colleague Albert Eisen is also a Prepare guru, so we can offer TA at any time for you all. So, all right, that includes my presentation. I'll open it up for any questions. What are your questions? What are your thoughts?
Thank you so much, Joe, for that excellent presentation. If anyone has a question, just raise your hand. Or should we unmute everyone? If you have a question, raise your hand and then we'll unmute you.
I'm going to check the chat box if there are any comments that came in. Oh, thank you. So validating. I'm so glad this was informative.
Vide, can you help with the chat?
So we have one raised hand from Denisha.
Denisha, yeah, go for it.
Hey, Joe, thank you again for sharing so much information. I loved it. And so as you were speaking, I was kind of fanning out myself. So thank you for doing that. And I do find that where you ask the questions in a workflow process is very important, because those are very intimate questions, especially really for anybody, but especially those who are already dealing with poverty-oriented issues, and they always have to justify why they need help, and they have to always let people know how poor they are and how much help they need. And so I have learned that asking those questions, or maybe trying to have a conversation where those questions come out and they can be answered, and you can go back and answer them as the conversation goes along, has been the most helpful in not making it feel as if it's like an inquisition into tell me why you need help. So yeah.
Yeah, Danisha, I completely agree. I feel like the most, I mean, using these methods of like talk story or having just a regular human conversation, right? And using some aspects of motivational interviewing, just like asking open-ended questions, right? To elicit just more thoughts, what's going on in the minds, and providing, some affirmations to reflect on what the patients or clients might be feeling, right? There are tactics, right? That I think that can help make this a comfortable screening process. Now, of course, inevitably, there will be some moments where the patients will feel really uncomfortable disclosing, right? Their demographic, information, their housing status, because there could be stigma attached, right, to that. So how do we practice cultural humility, right? How do we ensure that we're practicing cultural humility and just kind of really ensure that we're in this kind of learner position, right? And we're addressing any power dynamics that might, make patients or clients feel like uncomfortable, right, or hesitant. I mean, there's just, depending on the population it's served, there's so many nuances, right, with every single culture. Now, I'm just not just talking about race and ethnicity. I'm talking about like migrant farm worker status too, right? Those who are veterans, those who have experienced homelessness, young people, elders, right? So it's just so, yeah, there's just so many variations, but it's really just getting to know your patients. I think for folks who are from the community and they're engaging with the community members that they serve, that's, in my mind, the best practice, because CHWs, especially those who are hired from the community, they're fabulous. They're like the best folks to go to. So yeah, thanks for reflecting that, Danisha. Thanks for joining us for the last half hour, Jeanette.
Thank you so much. We only have 1 minute and just a couple more housekeeping items that we need to cover. I want to thank Joe again, and for all of you for your participation today. Let me share my slide real quick. Just want to show you that, just a reminder, next session, we're going to be hearing from Dr. Christina Bethel. It's really going to focus a lot on maternal and child health. She's going to be talking about screening with the whole family in mind. She'll be talking about some of those sensitivity issues that Joe also brought up. And she has a lot of shared and lived in experience with her patients that she serves. So she comes from a very passionate place. So please remember to sign in for that or log in for that next time. Here are some resources that I described: the STAR Center, the Siren Center, the systematic review of screening tools for those of you who need more information on screening tools. This is a resource that we developed at NCHPH on bridging the digital divide, and I'll post that in Moodle. And now it's time for the evaluation poll, which really worked well last time. So thank you so much for answering that. Let me launch it real quick. If you have any comments about how the Learning Collaborative could be improved, or what you found most useful, can you please add those to the chat? And so we can collect that. We can't do that on the polling, doesn't allow us for that. So thank you so much, everybody. Thank you for your time. And we'll tune in to you next week. Thanks, Joe and Fide and Chantel and Abdeen, for all of your help and for all of you that attended today. Thank you.
Thank you, Saki.
I'm going to keep the poll open just for a couple of minutes so people can answer. Thank you.
Thank you, Saki. Thank you, Abdeen. Thanks,
Thank you.
everyone. Nice meeting everyone.
And then just following up with Cherise about the first resource, we're going to be posting all of these on Moodle. Right? Yeah.
Yes, and I can send out the slides and the recording by email to you, just in case if there's some folks that don't like to use Moodle. It's no problem. I'm not going to force you to log in. Okay, thanks everybody. I'm closing the poll.
All right. Goodbye. Thank you.
Bye-bye.